right.
Okay.
Seems like we're on now.
Harry, you can see me.
All right. Thank you.
All right. So let's get started. First of all, thank you very much for having me. I'm sorry I could not be there in person. I would love to be there in slightly warmer weather. It's like 40 degrees here in Cleveland. And it actually snowed last night. So it would have been nice if I could have been out there, but this is the second best thing. So once again, thank you for having me. Let me just turn my email off because otherwise I'll just keep popping things up. Sorry. Just to add on Dr. Shrai, he was talking about getting the images on discs. Same goes for EEGs. If you're going from one place to another, changing providers, just make sure that the EEG is on a disc. So the next person, the new provider, can actually look at the images and not just look at the report, which may contain a lot of things that we don't really use the same language, we don't really use the same lingo, and we want to see more. So just to add to that, just make sure you have your EEGs on discs also. So I will be talking about intractable epilepsy, different seizure types, and I'm going to throw in the autoimmune also because it's kind of interesting and it's still an enigma to us. So let's get started. Here we go. So I thought I would just start with some basic things, understanding what is seizure and what is epilepsy, because sometimes the parents come to me and they say, my child has seizures, right? It's not epilepsy because epilepsy is really bad. And I try to clarify that it's not that it's bad or seizures are good. It's you have to understand the difference between the two. So if you break the terms down, what is seizure, what is epilepsy? Seizure is basically an abnormal synchronous electrical discharge from a large population of brain cells. The brain cells normally fire off. That's how I am able to speak right now. That's how I'm able to move my fingers, because the brain is firing in an organized fashion. So when you have a seizure, it's a totally disorganized, chaotic firing of those brain cells or brain neurons. So these abnormal firing neurons cause clear symptoms to develop. For example, a person falls down, shakes all over, or another individual may just have an aura. They sense something, they smell something, they see something. So all of those things are due to those abnormal discharges coming from the brain. Then when we're looking at seizures, we talk about provoked or unprovoked. So what do I mean by provoked? So provoked is basically if it was due to a trauma, you had a seizure due to a trauma, or you had febrile seizures. Only when you have a fever, you will have seizures. Otherwise, the child is perfectly fine. And then you have unprovoked, which are, as the term implies, totally out of the blue. You could be just sitting there watching TV and bam, you have a seizure. So what is epilepsy? So epilepsy is basically a recurrence of those unprovoked seizures. So you don't have any fever, nothing else going on. You have one unprovoked seizure, and then you have another second, third unprovoked seizure. Now you're dealing with epilepsy. So it's just the definition that we use to better understand, to better treat, and to better evaluate the patients more going forward. So just talking about epidemiology of epilepsy, 1 in 26 people in the US will develop epilepsy at some point in their lifetime, which is a big number if you think about the whole population. And about 60% of these patients will have partial onset seizures. So I'll go into what partial onset and generalized onset seizures are, but it's a huge number of individuals who will have seizures coming from one part of the brain as opposed to all the brain all at the same time. 65 million people worldwide have epilepsy, again, a huge number, and about 3.4 million people in the US had epilepsy in 2015 with another 150,000 diagnoses per year. So that's a huge number. 85 and 15% are in children. Again, because as we get older, the risky behaviors, the trauma-related epilepsy, once you have the trauma, then you can develop post-traumatic epilepsy, for example. So all those things, related tumors and all those things then come later, and 15% in children. So why people have epilepsy? That's a good question. Well, there's a genetic predisposition. We know that some epilepsies are genetically determined. If the parent had it, the grandparent had it, some of the children may have the epilepsy, just because just the way you transfer your eye color, your hair color, your skin color is the same way that epilepsy is written in your genetic makeup, in your genes, and you can pass those on. So that's a big reason, especially when we're dealing with pediatric epilepsies, and that's what I'm trying to focus on. Brain malformations. I think Dr. Shrai mentioned cortical dysplasias, and that's exactly what I'm talking about. So you have abnormalities in how the brain formed, and those malformed cortical neurons or brain cells can fire off abnormally and result in seizures and epilepsy. Infections is a big thing, especially in neonates and younger children. When they have meningitis, they can have encephalitis and all those things. Tumors could be just isolated by themselves or part of a bigger syndrome like tuberous sclerosis complex. Trauma is another big reason. Vascular malformations, when the blood vessels are not normal and they sort of form these jumbled up balls, and they can leak blood, or they're just pushing on the brain tissue, resulting in seizures and epilepsy. And then we have para-infections for paraneoplastic reasons, which are again taking us to that autoimmune, basically meaning that the body thinks that it's attacking outside invaders, when in fact it attacks its own cells, its own brain or kidney or heart. And in our case, we're more interested in how it affects the brain and attacks the brain. So when we are dealing with a child or an individual with first seizure, clinical examination is the most common thing. We want to understand what the individual actually did. So if you go to the doctor and say, our child had seizure or we had seizures, they would ask you exactly what happened. What did you know before you had a seizure? Were there any witnesses? What did the witnesses see? So we want to know as much detail as possible to see what exactly the seizure looked like. Then we get routine labs just to make sure that we're not missing anything. Your glucose was fine. You had, lunch and breakfast, and you were well hydrated, and all those things. And if there's suspicion to do other testing like lumbar puncture, we would do those if we suspect meningitis, encephalitis, or anything like that. Drug screening, and then EEG. EEG is a very, very important part because that really tells us if there are abnormal discharges or the EEG is totally clean. Okay. And then high resolution MRIs. I think you just heard about that, so I'm not really going to go into a whole lot of detail other than that early on in making a diagnosis of new onset epilepsy, we need to get a high resolution MRI. So going back to the history, there are things that are not epileptic seizures but look like epileptic seizures. So through history, through EEG, we want to rule out those causes of non-epileptic events so we can really treat the underlying issue. So there are a number of other diagnoses that can look like epileptic seizures but are not, like fainting and syncope. You pass out, but in history you would find out that the individual did not have anything to eat or drink, for 18 hours, and they were working hard, or they're running or out in the heat, and they passed out. So what can confuse fainting with seizure is the fact that you can actually have some shaking with fainting also, and we call it the convulsive syncope. Daydreaming is another one in children, and actually we see a lot of children in our epilepsy unit with this daydreaming episodes that can look like seizures, look like absence seizures to be more precise. Movement disorders. There are all these dystonias and other movement disorders, and even sleep-related movements that can look like seizures but are not really seizures. And then, of course, we have conversion disorder or non-epileptic paroxysmal disorder. So what are the reported risk factors for seizure recurrence? Basically, now we are talking about, going into epilepsy. So if there's remote symptomatic etiology, meaning there's already a brain malformation, already a brain injury of some sort. If the person has weakness on one side of the body, or leg is weak and you don't really know why, or one arm is smaller, or there's a small head or microcephaly. So all of those things would tell us that there's something else going on with the brain. It's not really a healthy brain to begin with. And then the EEG, if the EEG shows us abnormalities and the child does not have any other reason to have those abnormalities, then of course we're going to say, you know what, these are not provoked. The person is otherwise perfectly fine, but the abnormal discharges in the brain suggest that there's a high risk for subsequent seizures, and that's opens up the conversation to start medications in the family. This is a pretty striking graph which shows the estimated U.S. deaths per year, looking at these few main diagnoses. So cerebrovascular disease is huge, followed by diabetes and epilepsy. Epilepsy is not such a small number. And if we look at, about 50,000 U.S. deaths per year, which could actually be even more if you really start looking at all the causes. Someone is driving a car accident and resulting in death. If you start counting those and somehow figure out that the individual had a seizure, then the number of deaths is even higher. So let's switch gears and let's talk about the classification of seizures and epilepsy. So how do we approach a new diagnosis of epilepsy? So we split epilepsy, the main term, again, for recurrence of unprovoked seizures, into partial, which basically just means that one part of the brain starts the seizure. For example, the temporal lobe would start the seizure, as opposed to generalized epilepsy, okay? And then, they're genetic or injury related. That's the idiopathic or the symptomatic part. And why is that important? Well, that really is an important aspect to see how we're going to do the further testing, to prognosticate, to figure out exactly how long the seizures or epilepsy may last, what kind of treatment we're going to start. So we need to know exactly if it's partial epilepsy or generalized epilepsy. And then if we break the terms down for partial or focal and generalized, we go into simple partial, complex partial, and secondarily generalized. So it gets a little more granular. And then we look at absence, myoclonic, atonic, tonic. So these are basically all the seizure types that would be seen in those focal or generalized epilepsies. So if you're just looking at simple partial, just the examples would be somatosensory. For example, someone sees visual aura, they see something in their visual field, or they have a sensation on their skin, or feeling of déjà vu or jamais vu. Any of those things would be basically simple partial, which tells us that the patient did not lose consciousness and was able to describe their symptoms, or we were able to see their symptoms and they did not lose consciousness. So that's an important part of the simple partial seizure. So if it's simple partial, then what is complex partial? Complex partial is basically if you lose consciousness along with the other symptoms that I talked about. And that, again, is an important aspect for us to understand, because that tells us exactly where the seizure spreads and what part of the brain it involves, and where the seizure might be going next. So the seizure could start as simple partial, where the person is able to report their aura, report exactly what they're feeling, and then they lose consciousness. So it just goes from simple partial to complex partial. And once you lose consciousness, then that's considered a complex partial seizure. And then after the complex partial seizure, the person can go into a tonic-clonic seizure, which is basically full body stiffening followed by shaking. So as the seizure discharge spreads from one small area to a larger area, starting from simple partial to complex partial, it can spread to the other side of the brain, leading to this secondarily generalized tonic-clonic seizure. They usually last 1 to 3 minutes. There will be confusion, what we call post-ictal confusion. It's pretty violent and one of those scary looking seizures. And then we'll look at generalized seizures. We have the absence, myoclonic, tonic, atonic, and tonic-clonic seizures. Absence, again, you just stare off into space, unresponsive. Myoclonics are these quick jerks. Atonic is you lose tone and you just go down real hard. Tonic seizure is stiffening of the whole body, and tonic clonic is again generalized tonic clonic, where you stiffen and then you shake, and those are also termed quote unquote grand mal seizures. So have you gotten better in controlling seizures? Well, why do we say that? So this is a graphic that shows all the medications that are available to us or were available in the past. So if you look at way over to the left side, the first seizure medications actually came out in 1850, a long, long time ago. And since then, there have been a whole lot of other medications. Phenobarbital is actually 108 years old. It came out in 1912, and then phenytoin in 1936, I think. And after that, there was a little bit of a quiet period, then 1960s, 70s, and then you see those 1990 medications. Keppra should be there. I don't see, oh, Keppra is in 2000s. Well, it came out in 1998. And then in 2000, you have all these other new medications. With all the new medications coming out and these medications going back more than 150 years, 170 years, do you think we have improved seizure control? Well, not really. And that's the frustrating part. Despite this rapid rate in the development of newer anti-seizure medications, the rates of seizure freedom have not really improved. Patients achieving greater than 12 months seizure freedom. So these were all the studies from 1982 to 1991. This study looked at 142 patients. Only 63% had seizure freedom. 1992 to 2001, I remember a lot of these medications came out in the 90s and 2000 with newer medications. The seizure freedom rates did not really improve. Then 2000 to 2012, I think about 5 new medications came out, still the same rates. So there has been no improvement in the seizure freedom rates when you would expect that, hey, you know what, with technology, we're going to really help improve the seizure outcomes. So this is a graphic that basically shows the seizure freedom and anti-epileptic medications. So once someone comes to us with a new diagnosis of epilepsy, we start them on one medication. And a good 46% will respond to that first medication. Granted that the diagnosis was made correctly and the correct anti-epileptic medication was started. So that's an important key point, that if you achieve those things, then 46% could actually be seizure-free with that one medication. Second drug, that seizure freedom then drops drastically to 12%. When you're going to more than 2 drugs, 3rd to 11th drug, only 6% will have seizure freedom, which is a small number. And then if you look at seizures are not controlled, 36%. So this is just second to that first use medication. So that there's still this huge number of patients, no matter how many medications you try, they continue to have seizures. And that's the population that becomes more refractory, and that's the population that is intractable. So how do you define this intractability? Well, failing 2 or more medications used at adequate doses. So why do I say adequate doses? If you start a medication and you're on a small dose and develop a reaction to it and you have to stop the medication, that's not a medication failure, because you did not really give the medication a good chance. For example, if you did not develop a reaction and you were able to use a higher dose of the medication, it's possible that the medication would have worked to stop the seizures, but we never really got to that point due to side effects, and the medication had to be stopped. So adequate doses is an important part. And if you go and see your doctor and you're sitting with the doctor, just ask them, are we on a good dose of the medication? Or are we still on the low dose of the medication? Are we still on the lower side of the whole dose spectrum? Or are we as high as we can go? Are we at the middle? Because understanding that is going to really tell you when the doctor says, okay, increase the medication a little more, or we cannot really increase the medication. And about 1/3 of the patients will develop intractable epilepsy. And that's the pie chart I just showed you. About 36% would not respond to medications. It doesn't really matter how many medications used, those would not respond to medications. And that's basically how you would define intractable epilepsy or medically refractory epilepsy. You can use all these different terms. So why do some people develop intractable epilepsy, right? So if you have a neighbor who has epilepsy and you have someone in the household who has epilepsy, the neighbor's epilepsy may be very, very difficult to control when they're using the same medications as you. When you just use a small dose of a medication, it works perfectly fine. So we're not really clear, but we think there might be genetic factors at play, right? So certain genetic syndromes would be very difficult to control as opposed to other genetic syndromes. Dravet syndrome is one, Lennox-Gastaut syndrome is another one. So that makes a big difference. Symptomatic epilepsy, for example, if you had a physical injury or a metabolic injury, meaning there was not enough glucose, there was not enough oxygen, or there was trauma at an early age leading to scarring in the brain, that may lead to intractable epilepsy. Lesions in the brain, again, I'll use the example of tuberous sclerosis, where there are multiple tubers in the brain, and they can result in this intractable seizures, because now you got multiple foci of seizure onset and you can't really control them, again, because of the brain is so malformed. And other factors that may be inherent to the individual, again, their metabolic rate, how their body's made up, how the liver is functioning. So there are a lot of those things at play. What other medications they're taking, because we have to consider medication interactions, and maybe one medication is chewing up your other seizure medications and not really giving the seizure medications a chance to work. And one of the examples of intractable epilepsies is autoimmune epilepsy. And again, as I mentioned early on at the beginning, that it's still somewhat of an enigma and a very difficult epilepsy to manage and to control. So basically what happens with autoimmune epilepsy is that the body's own defenses attack the body or the organ, and in our case, the brain. So this usually happens in the case of pre-existing tumors or some kind of infections. So when there's a tumor forming, the body mounts this defense mechanism, and it forms the antibodies to go and attack the antigen or the actual tumor cells. And sometimes the tumors can have surface proteins that resemble the proteins in the brain, for example. So when the body forms this defense mechanism and it goes and attacks the tumor, it also goes and attacks the brain, thinking that this is a part of the tumor. And same thing with infections. If you have a virus infection and it mimics the tissue or the proteins on the brain, your antibodies are not only going to attack the virus, but they will also attack whatever looks similar or resembles that protein, and there's your brain, and it attacks the brain. And that's becomes an issue because of course you can't really shut down the immune system, but at the same time you can't really remove the brain for a little bit and then put it back in. These patients usually present with new onset refractory seizures. So the typical history would be that the person is perfectly fine, and either they had a little bit of an infection, a viral infection, for example, a bacterial infection, and a week or 2 weeks later, they start having seizures that do not respond to any medications. And when that happens, they present with this focal onset or generalized onset epileptic seizures. So basically starting in one part of the brain or starting everywhere in the brain in the absence of a prior history of epilepsy. So it's just new onset all of a sudden. And doesn't really matter how old or young you are, just because of the different reasons that you can have this autoimmune epilepsy. There's encephalitis typically, which is swelling of the brain. Progressive cognitive decline. So if the person was doing perfectly fine, they would be sleeping a whole lot, and they would just have this general decline in their cognitive abilities. And autonomic features, for example, heart rate changes, pallor, and those are the main things that you would start to see with these autoimmune epilepsy. Psychiatric symptoms are also a prominent presentation of this disorder. For example, behavior outbursts. Those would be the main things that you would start to see, especially in someone who does not have any such history. We can get EEGs that helps localize the seizures, and MRI of the brain may or may not show any abnormalities. That's why it becomes even more challenging to us, because you can't really find a cause. Again, you're looking for this cortical dysplasia, but there may not be any cortical dysplasia, and the MRI looks perfectly fine. And of course, you do the normal workup, the standard workup, which is look at the blood cells, look at the lumbar puncture. And when things start coming back negative and we can't really pinpoint exactly what's causing the seizures and where the seizures are coming from, then you say, okay, it's a diagnosis of exclusion. We have excluded all the common causes. The MRI is fine. The blood looks fine. Now we're really going to look into other causes, and let's look at the autoantibodies, or the antibodies that might be attacking the brain. And going back, looking at the history. So basically, you're looking for any tumors that may be responsible. And you can actually pick those things up when the tumors are still very, very small. So you can manage those very early on. Or if there was an infectious process, then of course, you just wait because the infection is over, but the antibodies are still there attacking the brain. Workup, as I mentioned, includes lumbar puncture, testing of autoantibodies with patients without any clear reasons for having this really violent onset of epilepsy. Therapy is based on the treatment of the underlying reason for the type of epilepsy. So for example, if a tumor is detected and you scan the whole body, there are many different types of scans you can do, PET scans and MIBG scans and all those. So once you do the scans, and if you do find a tumor, the treatment could be removal of the tumor, because that's what's really the antibodies are trying to attack. But in the meantime, you have to control the seizures. So anti-epileptic medications are essential, and you can't really avoid those. And what happens to the antibodies that are already in the system? So what we do is we try to suppress them somewhat, giving high dose steroids, immunoglobulins, just to slow the attachment of those autoantibodies, and plasma exchange, where basically you're taking the antibodies out of the blood and just getting rid of them. So these are the first line medications. And if this does not work, then you have immunotherapy, where you're basically giving immunosuppressive medications, where you're basically trying to suppress this immune system down that's attacking your body. But that same immune system is designed to defend your body. So it becomes very challenging to manage. But first line, again, medications are high dose steroids. You would use immunoglobulins, plasma exchange. And this is a diagnosis of exclusion. So you have to make sure that you're ruling out everything else before you go down this road. So how do we treat intractable epilepsy? So the reason I put intractable in parentheses is, you start treating epilepsy, and then if it becomes intractable, you go and treat the intractable part of the epilepsy. So how do we treat this epilepsy/intractable epilepsy? Well, you diagnose epilepsy, and then, as I mentioned, the first thing to do is pharmacologic therapy, which is basically your medications. Okay, so that's the first thing you would do. Then you would consider non-pharmacologic therapies, which is basically going away from the medications if the medications have not worked, and try something different. And I'll mention those things. And then we have surgery, and surgery is not for everyone, only for a select group of patients. And I will talk a little about who those patients might be. So pharmacologic treatment for these patients with epilepsy or intractable epilepsy, you start treatment of any epilepsy with anti-epileptic medications. The choice of the medication basically depends on multiple factors, but the most important thing is a correct diagnosis. If you misdiagnose absent seizures, for example, for complex partial seizures, because both are characterized by staring off into space, then you may pick the wrong medication and actually make the seizures worse. So you may not have intractable epilepsy, but it was just that the medication was not the right medication for that epilepsy type. So that's an important part for us to do, and that's why we do the evaluations. We ask the questions, repeated EEGs, MRIs, all those tests. Normally starting with one medication, to which other medications may be added to improve or to control seizures. Again, remembering, keeping in mind that the definition of intractable epilepsy is you failing 2 or more medications. And if that happens, you fail 2 or more medications, then we go down the non-pharmacologic treatments, which is basically diet. Ketogenic diet is a big one, and modified Atkins diet. So ketogenic diet is high fat, very low carbs or no carbs, and low amount of protein that has shown effectiveness in certain seizure types and certain underlying pathologies, certain underlying reasons for epilepsy. For example, if you have a glucose transporter defect, which basically means that the glucose is unable to go into the brain, and if brain is using glucose as the main fuel and you're not really providing it with the correct amount of fuel, it's not really going to work right, and it's going to produce seizures. So you provide an alternate source of energy, which is basically in the form of ketogenic diet. So for someone like that, ketogenic diet would really, really help. And that intractable epilepsy that you were dealing with initially with medications and not really responding to medications may just respond promptly to something like ketogenic diet. But it's very difficult to do because you have to be very, very precise in how you are making the meals. And not everyone likes to eat or drink a lot of fat, and especially kids, if they're cognitively intact. It's a challenge to ask them to drink a glass of heavy cream, for example, just because you want to make sure that you get all the fat in them. And then the modified Atkins diet is a little easier to do, to prepare than ketogenic diet, and the calorie counts are not as strict as they are in ketogenic diet. Outside of diets, there are other devices, the neuromodulation devices like VNS or vagus nerve stimulator. That's also pretty helpful and used for many different types of epilepsy. So why don't we go to vagus nerve stimulator first? Well, going back to the pie chart I showed you, that a good 46% of patients would respond to a first medication. So we know that the numbers are higher for a medication responsive epilepsy than to vagus nerve stimulator, for example. So vagus nerve stimulator, it's a surgical procedure. It's a small device that's implanted in the upper part of the chest on the left side, and small nerves go up into the neck and they connect to this nerve that starts in the brain and sort of comes down, but loops around back up and goes into the brain. So we want to stimulate that part of the vagus nerve that goes back into the brain in order to control seizures. The second device is responsive neurostimulation system, or RNS. That's basically a small device that's placed in the brain to stimulate a part of the brain. So for example, if someone has focal epilepsy and they're not a candidate for epilepsy surgery, you can provide electrical currents, tiny electrical currents. And that's what vagus nerve also does. And same thing with RNS and DBS, that they provide small amounts of currents to that part of the brain and basically try to suppress the overexcitement or the overactivity of the brain cells. So these 3 devices are FDA approved, and we use them. But first we go through the medications, and then if those are not working, I usually go to ketogenic diet first before I go down the surgical route. So these are not for everyone. There's certain diagnoses, especially if you're dealing with children with metabolic disorders, that may not be suitable candidates for ketogenic diet. They may already have issues with metabolizing fat. Their cells are not capable of metabolizing fat, and you don't want to give them tons and tons of fat in the form of ketogenic diet. Before we start ketogenic diet, we make sure that we consult with our metabolic colleagues and genetic colleagues, and they do all the proper testing to make sure that this individual is in fact safe to be started on ketogenic diet or even modified Atkins diet. So it's not that you can just use it in everyone. There's a select group of patients, or if it turns out that they have that glucose transporter defect, then that would be the perfect thing for them, as opposed to another child who has a different disorder. Same thing with vagus nerve stimulator. So vagus nerve basically comes down from the brain through the neck, and some of the fibers go to the heart also. So if someone has heart problems, heart arrhythmias, then we are a little cautious and we don't want to mess things with the heart. And the RNS system, similar things. We have to select the right patient in order to make sure that the patient is safe, and that's the biggest thing, and then that we are doing the right thing as far as trying to control the epilepsy. Surgery is a big part. So we also have what we call a level 4 epilepsy monitoring unit, where we do epilepsy surgeries. The patients have electrodes placed in the brain. They come to the epilepsy unit and we monitor them. We map out the brain, and then we send them to the neurosurgeon for epilepsy surgery. So mapping out the brain basically means that you're stimulating and you're trying to make sure that the brain that's producing the seizures does not have any vital function. So even if it was taken out, the patient will still be able to function as normally as possible. So resection surgery could be quote in 1 stage or 2 stage. So 1 stage would be if someone has right temporal lobe that's a little malformed, and they're right-handed, so we know the right temporal lobe may not really have any vital functions. So you'll talk to the neurosurgeon, and it's just the temporal tip. It's just 2 centimeters of the brain that's going to come out. It's not really going to leave any lasting effects. Then the neurosurgeon will just take them to the OR and just remove that small part of the brain, and that's about it. As opposed to a 2-stage surgery, where you think the area that's producing the seizures may actually be larger than what you can see on the MRI, for example, or any other imaging study like a PET scan. In that case, you need to investigate a larger area of the brain, and you just can't really tell the neurosurgeon to take it out. The second important reason would be if the epilepsy is coming from an area that has that is of importance, for example, speech and language area, for example, if it's the visual field area, so any of those, like memory area, which is called the hippocampus. So if the seizures are coming from any of those regions, then what we do is a 2-stage surgery where you can map the brain out, and you provide the electrical stimulation and see exactly how important that part of the brain is. And the third thing is, once we, and I will show you a picture in a second, once we put the actual electrodes onto the brain, we can record seizures, and we can really pin down on exactly how small of an area is producing seizures. So when the neurosurgeon is planning their surgery, they can say, okay, the smallest area that needs to come out is what we're going to remove in order to render a person seizure free. The second type of surgery is disconnection surgery. So basically, in disconnection, you may not be removing anything, any part of the brain, but you may be disconnecting. So we know the frontal lobes are connected. The temporal lobes are connected to the frontal lobe, to parietal lobe, and the back part is connected to each other. So what you're basically trying to do is you're trying to disconnect the connections between the occipital lobe to the temporal lobe, or the temporal lobe to the frontal lobe. And what you're doing is, if this is the part that's making the seizures, and the seizures keep spreading to the frontal lobe, you're basically cutting that connection. So you're basically cutting off that road or the supply route, so the seizure just stays there without causing any symptoms, without going over to the frontal lobe, for example. So that's another important surgery and distinction that we have to make when we are talking about epilepsy surgery, that nothing will be removed, but things will stay still in the scalp, but the neurosurgeon will come and disconnect things. Then there is palliative surgery, where the seizures are so many and so frequent, and we cannot really remove a certain part of the brain or disconnect a certain part of the brain, that we have to do something to reduce the seizure burden. And majority of the time, we do these palliative surgeries in individuals who have seizures with falls, because falls can really result in a lot of injuries, broken facial bones, teeth, gashes. So a palliative surgery basically would alleviate the frequency of seizures or decrease the number of seizures, but the patient may continue to have seizures. Before we do epilepsy surgery, we take someone in for epilepsy surgery for intractable epilepsy. A lot goes on. So video EEG, sometimes we take the individuals off anti-epileptic medications just because we want to see the seizures. We want to make sure that the seizures are coming from one part of the brain, and this is the part that needs to be removed or disconnected or whatever needs to happen to render a person seizure free. So we discontinue the medications and we record a number of seizures before we put the medications back on. Then there may be source localization. So source localization is basically all this computer softwares that tell us exactly where the seizures might be starting or where there's spikes or those little sparks may be coming from. Again, everything to help us localize the area of seizure onset. Of course, we get the MRI scan of the brain. That's not a plus minus, that's always a plus. We always get that. Looking at any lesions that we can identify on the brain, and it's easier for the neurosurgeon and for us to say, okay, this is the part of the brain that's producing seizures, so removal of it is going to render the person seizure free. PET scan of the brain. So as I mentioned earlier, that the brain uses glucose as a normal fuel. And what the PET scan does is it looks at the glucose metabolism. So it's basically, if you think of the brain as an engine that's using the gasoline, you're trying to see what part of the engine is not using the gasoline correctly, and that's what the PET scan does. So if there's a certain cylinder where the gasoline is not going in the right way, you can say, okay, this is where the problem is. And then when you go back and you look at the MRI, you say, this is where the cortical dysplasia is on the MRI. And then you go back and look at the EEG and you say, exactly, that's where the seizures are coming from. So everything matches up and you can say, we know this is what's causing the seizures, and now we can safely address it and possibly resect it. Then there are other tests that are more not really something that we always get, but are more on a case by case. We look at the cases and then we decide if we're going to do those tests or not. So one of them is called an ictal SPECT. So if the seizures are unclear on the EEG and the MRI doesn't really show anything, PET scan doesn't really show anything, and we're not really clear what part of the brain is producing seizures, we do this test called an ictal SPECT, where basically a nurse or a technologist sits with you in the room, in the epilepsy room, while you have a seizure. And as soon as the seizure starts, they inject this tracer that goes into the brain. And then we take pictures later on, like a CAT scan. The other test is WADA test. So it's actually named after Dr. Wada from Japan. And this is to figure out which part of the brain is dominant for language and for memory, because those are the two very main important things that we look at before a resection is done, especially in the temporal lobe surgeries. And the way the WADA test is done, you basically numb one side of the brain and you see if the person is able to speak or to retain information provided. And then you do the same thing with the other side of the brain. And if the person does not remember anything during the WADA test and they're unable to retain any information provided, we say, okay, that part went numb and this is where the memory and the speech is. So that is also needed in certain patients, but not in every single patient, like EEG and MRI and PET scan. And then we do neuropsychological testing, because again, that's another part of the whole workup that tells us if a certain part of the brain is working correctly, or if there is some dysfunction in it. For example, if someone has issues with math problems and they cannot really do simple math, then we can say, okay, it's going back to the dominant side, dominant parietal lobe on this part, and this is where we see the MRI abnormality, PET scan abnormality, video EEG abnormality, and everything again just matches up to that one place. We can say, okay, we are very, very, very confident that this is where the seizures are coming from, and then we plan the surgery accordingly. So what does the surgery look like? And when I mentioned the two-stage surgery, what happens? Well, there are different types of things that we can use. Again, if you look at this cartoon of a brain, we can place what we call a grid, which is basically a whole bunch of electrodes, and they sit right on top of the brain. They actually touch the brain. And then, for example, if these are the areas that are producing the seizure, then we can go back to the neurosurgeon and we can say, okay, 29, 37, and 38 is where the seizures are coming from. But when I was mapping the brain to look for any important parts, I found out that the electrode 36, 44, and 45 carry this vital information, for example, speech area of the brain. So do not touch those, but you can take this out. So the neurosurgeon has to be very careful in removing the seizure focus and leaving the essential parts. So this is one thing that we can do, and this sits on the surface of the brain, which is called grids. Then the second one is something we refer to as depth electrodes. So if this is a grid and sits on the surface of the brain, these actually go inside the brain. They pierce the surface of the brain and they go to deeper parts of the brain. And these are a lot of depth electrodes placed. You don't really need to do a craniotomy, basically remove a part of the skull, because you can just put these in through a small drill, as opposed to a grid where you have to remove a part of the skull because it's so large. You have to actually have a large part of the brain exposed to place that grid. And then the depth electrodes look at the deeper parts of the brain. For example, the hippocampus, which would be sitting right in there in the deeper aspect of the brain. So the hippocampus or the other deeper parts of the brain need to be looked at with these depth electrodes. And then we have other things called strips, which are just these individual sort of smaller electrodes. So if you remove this thing and just split it up into two different things, we'll just call those as strips, and then you put strips. And again, strips you can put in the under the temporal lobe, for example, which would be right here, right underneath, and look at how the brain is firing off and if there are seizures coming from that region of the brain. And then the palliative procedure that I mentioned earlier is usually a corpus callosotomy. So corpus callosum, which is this part, it's a bundle of this white matter that connects one hemisphere of the brain to the second hemisphere of the brain. And as I mentioned, these fall seizures or these drop seizures where you go down is because the whole brain synchronizes all at the same time and just shuts down for a fraction of a second, and that's where you lose tone and you just go down. So the idea is that you disconnect one brain hemisphere to the other brain hemisphere. So even if the seizure starts here, it cannot go to the other side and recruit the other part of the brain for you to lose tone. And that would really cut back on the seizures that can really cause injuries resulting in falls and all that. So intractable epilepsy impacts the patient in a lot of different ways. Medically, because you continue to have seizures, you're taking all these medications that have side effects. You end up in the hospital a whole lot more than you would like to be, and you can't really do anything. It has clearly social impact because you're not really independent, right? So 18, 20-year-old patients of mine who have intractable epilepsy, they are not independent. They cannot do what other people are doing. So that's a big impact. Then the cognitive effects are also important to discuss. So cognitive effects could be due to the frequent seizures, or they could be due to the additive effects of medications, because if you have intractable epilepsy, most likely you're on multiple medications and not just one medication. And the additive effects really impact your cognition. And then, of course, psychiatric, because again, if you are cognitively intact, a lot of these patients would be depressed or have anxiety, again, looking at their peers of what's going on. That really impacts the individuals with intractable epilepsy. So just to conclude, I have 10 minutes for Q&A. Accurate diagnosis is essential for choosing the correct therapy. Again, if you cannot make the correct diagnosis of epilepsy and we're treating the wrong thing, then it may appear as intractable epilepsy when it really is not. So that's an important part and first step. Many different seizure types exist. Sometimes multiple seizures can be seen in the same patient. and that could depend on the epileptic syndrome that you're talking about. So syndrome is basically not just the seizure type, but the bigger picture of what's going on with the individual. Intractable epilepsy is relatively common. Again, a third of the patients would have it, and it requires extensive workup, treatment options, and a whole lot of discussions regarding how to treat epilepsy, intractable epilepsy. And treatment options for intractable epilepsy are tailored to the underlying reasons for epilepsy. For example, you can do a VNS, you can do a ketogenic diet, or you can do surgery, epilepsy surgery. So you have to see exactly why the individual has seizures, and then tailor the treatment accordingly. And that's all I have. I'll stop sharing. Questions? I have some questions here. Please, what does intractable mean? If my daughter's seizures are not under control, is that intractable? And do you guys want another word for it? By the way, my daughter has Unverklandberg. So basically, as I mentioned, if you fail 2 or more seizure medications at adequate doses is basically what we were talking about as intractable epilepsy. And if you're talking about a progressive myoclonic epilepsy like Unverklandberg, then yes, you're going to try many different medications, and that's basically what we're talking about as intractable epilepsy. So another question is, what metabolic tests need to be done before starting ketogenic diet? So that's important, especially in the pediatric population, because in the children, we don't really know what might be causing seizures as opposed to adult patients. And basic metabolic labs, you want to look at lactate. That's one of the things we look at. Then there are more specific things. If you suspect pyruvate dehydrogenase, for example, deficiency, that's where the ketogenic diet would be very helpful, as opposed to pyruvate carboxylase deficiency, where ketogenic diet is actually going to make things worse. So before starting ketogenic diet, especially in a child, because as we grow, if we have those underlying pathologies, they would declare themselves one way or another with hypotonia or something or another, and you would end up seeing a geneticist or a metabolic doctor, and they would address those and do the targeted tests. But if it's a child, then a metabolic genetic person would target all those, and they would make sure they test for all those specific metabolic disorders. And actually, even our dietitian, before she starts the therapy, and we don't start the therapy, we just consult with a dietitian who then talks to the families, is actually recommends basic labs just to make sure that everything looks okay in terms of glucose, in terms of fats, and in terms of all those things. So they also check basic labs before starting ketogenic diet. Another one is, my son was diagnosed with antibody-negative autoimmune encephalitis 3 years ago. He was adequately and quickly treated with IVIG, steroids, and Rituxan. Over the following year, he had seizure recurrence and now has intractable epilepsy with few partial complex seizures a week. Do you see this progression of seizures with autoimmune epilepsy that has been adequately treated? Would he benefit from additional immunotherapy, since his seizure foci seem to have increased and seizures are getting more frequent? He has been on modified Atkins and VNS, but no improvement yet. So a repeat course of steroids may not really help, because what we're trying to do is early in the course of the therapy, when we assume that you have all these antibodies that are just coming out and attacking the system, we want to suppress those in the acute state. But if you continue to have seizures, that means there might be a different mechanism or different reason than what happened initially. Yes, initially it was autoimmune, but now maybe there is some kind of injury done to the brain, and the seizures would continue to recur, even though there may not be any of those autoantibodies left. In this case, if he's on modified Atkins diet and VNS, I would go back and look at what other medications were used, because again, you're doing all the things that that should be done to control the seizures. So I would go back and explore the type of medications that your child has taken, and if there's anything else, or switch from modified Atkins to ketogenic diet, which is again a lot more strict to do, but it could be an option to look at. Are there any treatments specific to treating the potassium channel? My daughter has KCNA2 mutation with the gain of function. Wow, that's a tough one. Sometimes we can use potassium channel blockers. Sodium channel blockers. So I don't know if they used any of the sodium channel blockers. For example, trileptal, carbamazepine, all those are sodium channel blockers. With the those medications may help, but then again, you may need a combination of medications to control these kind of seizures. Any other questions? So I guess the important things to remember are, when do you call it intractable epilepsy, adequate doses of medications used, and what kind of treatments are available. With KCNQ2, potassium channel epilepsies, again, sodium channels, with sodium channel blockers, with autoimmune epilepsies, that's always a tough one because, yes, you're right, the seizures do come back, and that's when we just try to manage them with anti-epileptic medications at that point. Any other questions? All right.
All right.
Well, thank you for having me.
Giving us a talk. And I guess no more questions.
Absolutely, my pleasure.
All right. Thank you so much. Have a good evening.
My pleasure. Thank you. You too. Thank you. Bye-bye.